What's good, YouTube? It's your man CJ, aka the High Value Nurse, checking in once again, back with another video. Ladies and gentlemen, I done started this watermelon fast. I'm driving home from my travel assignment. I don't know if it's just my body's first day of reacting to it, of having nothing but watermelon, but I was so sleepy on the way home. I'm just like, bro, what the heck? It literally took me like almost what? I left at like 7:30. It's 2 something now, so yeah, it took me a minute because I just kept getting tired. And I never get that tired. Usually I'll just take, like a 30-minute nap before I head to the crib. Then I can make the drive home. But today, I don't know. I think it was just my body getting used to it. But anyway, I wanted to talk to all my long-term care nurses out there in the game. And also I wanted to talk to all the new nurses that may be coming in to work in long-term care and let you know one thing that may be quite difficult when going into that setting. Let's talk about it.
But you can live pretty well by yourself.
Now, before we get into the video, I need you to like, comment, subscribe, hit the notification bell. It helps with the YouTube algorithm, helps get this out there more, and just lets me know you appreciate what we got going on over here at the channel. Thank you in advance. So, let's talk about it. Now, when we graduate nursing school, you go in there, you all bright-eyed. Initially, we all put the S on our chest. When we graduate, we say we're gonna be the best nurse we can. We got the Clark Kent Superman syndrome. We want to save the world, and that's usually how it is for most nurses when they first get in. I don't think anybody goes and graduates from nursing school saying that I'm only going to do it just for the money. I don't care about this. I don't care about that. It's just a business. No. Usually that comes later after you've been exposed to how it really is. But for the most part, you want to put your cape on, which is cool, and I understand that. And with that being said, you have to understand that one of the hardest things in long-term care, and this may happen in the hospital as well, but I don't work in a hospital, so I'm only speaking about long-term care. One of the most difficult things that may occur is that you will have residents or patients that you have developed great relationships with that will become non-compliant to care or who just don't care. Let me tell you something, ladies and gentlemen. For the most part, nobody wants to be in a nursing home. It is usually a last resort option. So you have to go into it thinking about it from that mindset. It's usually a last resort option. Now, usually you'll have the outliers that may be getting out of jail or something like that and that are homeless, and this is a good option for them. This is better than being homeless and in jail. But for the most part, when somebody comes to the nursing home, it's usually due to them not being able to take care of themselves or them not having any family to take care of them. And it's really usually a negative situation. And that can spill over into certain patients not caring. You can develop relationships with patients, and after so long, they can become non-compliant, or you can have patients that are just non-compliant soon as they touch down in a facility, as soon as you become their nurse. And you got to understand, you have to deal with that from all aspects. As a nurse, your job is to educate and inform. Yes, we all took the oath to do no harm. Yes, our job is to help people get better. Yes, our job is to help heal the sick. But at the same time, ladies and gentlemen, you cannot force anyone to do what they don't want to do. I'll give you an example. Now, in a nursing home, you'll have people that have very crucial treatments that they need to oblige by, such as, going to dialysis on a regular basis. All of a sudden, you'll have a patient that just no longer wants to go. For whatever reason. They could be depressed. They could be just angry at the world. They could be angry at the situation. But for whatever reason, They just choose not to go. And your job as a nurse is to encourage and to educate. The only thing you can do is try to encourage that patient to go and say, hey Johnny, listen, it is super important that you go. You need to go, because if you don't, your blood's not going to get filtered, yada, yada, yada. You go through the whole process with them. They say, nah, I'm just not feeling it. I don't want to go. I don't want to go. I don't want to go. And that is what it is. You can't force them to go. The only thing you could do is let the doctor know and chart and document. Now, in some instances, that may be very difficult, because that may be a patient that you've grown to have a relationship with. You know what I'm saying? You've taken a liking to, and it happens. I don't care. It's very difficult to go in these places and inevitably not find somebody that you take a liking to as a patient. You know what I'm saying? That's happened to me several times. There are several patients that over the years that I've absolutely adored. And unfortunately, some patients, rather they are starting to lose the mental ability to make the right choices for themselves, or they just simply refuse. Sometimes they will refuse care. You can have a situation to where you have a patient that's on a specific diabetic care regimen, and all of a sudden they just choose not to go, not to go, not, you know what I mean, not to go, but choose not to be compliant with their medications. For example, you take a patient's blood sugar, the blood sugar is 387. They need, I don't know, whatever the sliding scale is. Let's just say they need 9 units of Novolog. And the patient's like, no, I'm straight. I'm not taking it for the day. Well, George, why are you not taking it for the day? And George, these are just random names I'm making up. This is not any patient that I've ever worked with in particular, but I'm just saying these are just random names for those who, y'all who like to be on that crazy stuff. Well, George, why you don't want to take it? Well, I'm not feeling it today. I don't need that. Or you gonna have patients sometimes that's just real rude about it. What the F do you know? That's real talk. And I think that is a real difficult thing for those who come into the game with, with the Superman symbol in their eyes. You dig what I'm saying? With the cape flapping in the wind. And usually after so much of that, and that's why I say too, it's an individual basis type of thing. Because after so much of that, I can see how that kind of can create compassion fatigue. You dig what I'm saying? Because I've been to nursing homes, I've worked and I picked up shifts in nursing homes where you've had several patients cuss nurses out, cuss staff out, tell you what they not gonna do, tell you what they not gonna take. It don't matter how many times you ask, it don't matter how many times you educate, it don't matter how many times you redirect. And your only thing you can do as a nurse is to document very detailed. Let the physician know. The physician is more than likely aware, because if this person is doing this, they probably have a history of doing it, and so on and so forth. You have to go on and move about your day, because unfortunately, when you're working in long-term care, you do have a lot of patients that you have to take care of. And that can be a very disheartening thing, because you are literally watching a person, break down, and you're watching a person decline, literally on a daily basis. I had one situation to where I had a resident who was a DNR. She wasn't hospice, but she was a DNR, and this was kind of unique versus what I'm talking about, but she wanted, so I came in, I did my, initial assessments, I got her vitals and everything like that. And mind you, I wasn't too close to this lady, but I had known her for about 2 months, you know what I'm saying? And, we have good talks and everything like that. I liked the patient. She was very cool, you know what I'm saying? So all of a sudden, one day I go into the room, did her assessments and everything like that, and I'm bringing her routine medications. These are the same pills that she gets every night. So I go in and walk into the room, and she goes, you know what? I'm okay for today. I'm not going to need these. And, it kind of threw me off, because she's always compliant with her medication. She's never been the one to refuse. And usually she would ask for them. And I'm like, well, what's wrong? And I'm trying to figure it out. I'm doing my investigation, trying to figure out, well, why don't you want your medication today? I'm just not feeling it. I'm like, are you sick? Is something going on? No, I'm not sick or anything like that. I just don't want it. So I said, okay. So I have to document that as a refusal. I asked 3 times, and I have to let the physician know. Cool. And she was on her own responsible party. So she wasn't, demented or anything like that. She was an ANO times 4. For those of you who don't know, the alert and oriented times 4. Meaning she was, with it. So about 2 hours later, she had another medication due at midnight. Or 3 hours later, whatever time I came. I go in there and she goes, no, I'm not going to need it. She said, I'm going to be honest with you. I'm probably not going to be here within an hour. I said, well, what do you mean? Are you leaving the facility or something like that? She said, no. She said, no, I'm probably going to die. She said, I'm probably going to die within an hour. Now, I don't know when you close to death, if you can just tell. But I'm just like, okay, well, I'm like, I'm trying to re-educate her. I'm like, oh, don't say that. You never know. Just trying to figure out the right things to say. And usually, you'll have NCLEX questions that when these scenarios come up, what do you say? And the perfect thing to say. But I'm telling you, the NCLEX is not a real world. When you get out here in the real world, it's different. So I'm just like, okay, I document and everything like that. I came in, I checked on her a half hour later because she kind of spooked me. She was there. Half hour later, she was there. Okay, cool. Left the room, half hour later, and I promise you, it was probably about 31 minutes. I did another check. Gone. She was gone. So, we did the protocol and everything like that. And she was gone. That lady knew. Gone. And that's just another take on what I'm presenting to you within this topic. But things like that happen, and that can be a little disheartening because, like I said, you build relationships with certain people and they pass away. You know what I'm saying? I'm not going to say that was from her being non-compliant, but that was just an example of how situations like that can occur and how they can take place. So you may have a situation where I had another situation to where I had a patient. I didn't really know this guy, but he was a hospice patient. He had bone cancer and he was in a lot of pain, and he just refused to take any kind of pain medication, and he was suffering and suffering and suffering, and he was with it enough to make the choice. He was alert. He was not demented, and he just was suffering. And some people just do not believe in taking pain medication. And it was just to the point to where we let the hospice nurse know. And the hospice nurse was like, listen, it's nothing. He is refusing. We cannot make him do it. And then he died I think he died like a day later. But it's just those situations like that. That's a difficult part because you literally are watching somebody suffer. Now, that's not typically the norm, but you do get situations like that. I've had that situation probably one other time in my career. So when you go into these nursing homes, you have to understand that you have some patients who simply don't care. You have some patients that are very prideful. You have some patients that just don't believe in taking medication. You have some patients to where depression can get the best of them and they just stop wanting to take medications altogether. There are various reasons on why people stop doing certain things, but your job as a nurse is to assess, document, educate, re-educate, and encourage. And that's pretty much it, ladies and gentlemen. That's really all you can do. And that can be difficult when you try not to get your feelings involved, but it happens, and just be aware of it. Ladies and gentlemen, my name is CJ, aka the High Value Nurse, checking in once again, back with another video. Hopefully you enjoyed this video topic, and if you have, thank you. And until next time, if you don't do nothing else, get paid, young nurse, get paid. Peace.